Good morning, everybody. I hope you can hear me. We're trying to figure out, there's usually a place where I can see whether you can hear me or not. Okay, can everybody hear me, please? If you can hear me, just put up your hand. Where do I get? You have to excuse me. Yeah, good. So you can hear me. Fantastic. Good morning or good afternoon, wherever you are. It's indeed my pleasure to be running this session. If you would excuse me, it is also an advert for an online course which I will be running starting from next weekend. This slide is just telling you who I am. I'm sure most of you probably have heard about this strange man. So I've been running MRCOG courses since 1999. And I think of the over 12,000 members of the college, just excuse me, I need to get the webinar screen on so I can see what's going on. Oh, no, I'm messing it up once again. Yeah, there we go. Okay, great. So I just need to be seeing this as well. So, okay, just coming back to that. So I can see how many people are on the on the course itself. So I run this course at the University of Leicester, and I was saying that of the over 12,000 members and fellows of the college at the moment, I have been very, very lucky, or it's been a real privilege for me to say that at least a quarter of them have passed through Leicester and have passed through me. So I'm very proud of that history, and I'm hoping to continue with this for a little while. As I said, we're going to run two courses. The first one will be from the 8th to the 23rd of May. Because it's an online course, we want to run in such a way that it doesn't interrupt people's work commitments. So we have this course on 3 weekends, starting from the 8th of May, Saturday and Sundays. Then the second one from the 5th of June to the 20th of June. And to make it easier for anybody who wants to attend, there are pre-recorded lectures, so you can listen to the lectures at any time you want. But there are about 650 single best answer questions and close to 650 EMQ questions with a mock exam. So the mock exam has got 100 SBS and 100 EMQs. And the plan is that you listen to the lectures at your own time, but during the weekends, we will discuss the questions, exactly what I'll be doing today. And hopefully that will allow us enough time to explore the questions, to take questions from you, and hopefully prepare you for the exams. I've attempted as much as possible to include some of the recalls that have come from previous exams, and hopefully that will help you to try and understand the standards that you have for the exams. If you want to register for the course, please, this is the link, www.cisco.com, the Konje, and you will be able to register for the course. So back to the idea of today. Some of you probably would have seen some of the questions that I set, which we're not discussing today. Those questions are made free, and I will continue to make questions available if time permits, just to help those of you who cannot attend the courses to have a go at them. Obviously, there wouldn't be many questions like you've had this time. So that's just an opportunity for you to visit the site, have a look at the questions, and try some of them. So we want to, there are 98 attendees. There was supposed to be 100 and, well, I see maximum 101, but I was told yesterday that we had over 144. So I'm not quite sure how this will be accommodated. I'm sure that the manager who is organizing all of this will make that possible. So the first question is, what is the age from which children and adolescents presenting with gender dysphoria should be referred for assessment to the Gender Identity Services in the UK? The age of consent in the UK is 16. So once a child has reached the age of 16, they can literally provide consent for most things. But of course, when they want their gender to be reassigned, the belief is that 16 is too young for that decision to be made. And so we have to wait until the age of 18 before that decision can be made. So the correct answer is 18. And I'll read out the explanation for you. Children and adolescents presenting with gender dysphoria should be referred for assessment to the GIDs, which are the Gender Identity Services, an NHS service available to all those under the age of 18 years. So they are referred from the age of 18. That service is available to all of them. It doesn't mean that they will immediately be allowed to undergo the changes that would take them into what they think is the right sex, but that's when referral should take place. The next question is, why should testosterone levels be monitored in a 25-year-old trans woman who is on hormone treatment? So who is a trans woman? A trans woman is a man who wants to become a woman, and a trans man is a woman who wants to become a man. And you need to understand these terms, because if you have a question coming up in the exams on this topic, and this topic is actually covered in one of the recent articles in the opt-in talk, if you don't understand those terminologies, you probably get very confused. So a trans woman is a man who wants to become a woman, so he feels that he's actually a woman in the body of a man. So the question is, why should we monitor testosterone levels in this trans woman? And the correct answer is A, to ensure that adequate suppression to well below normal male range has been achieved. So you need to suppress the testosterone levels so that they then start developing the external features of a female, and until you've achieved a level where the levels have been suppressed significantly, you won't be able to then start assigning the gender. So testosterone and dihydrotestosterone levels should be monitored to ensure that adequate suppression to well below the normal level, normal male range has been achieved. This ensures that the androgenic effects of testosterone and dihydrotestosterone are minimized. And that's really, really important. Now, what is the most serious risk of testosterone hormone treatment on a gender dysphoric or trans man patient? The correct answer is polycythemia, which is D. Testosterone induces the production of erythropoietin. And because it reduces the production of erythropoietin, that causes an increase in production of red blood cells, and then polycythemia is a major risk factor. And you know, when the patient has got polycythemia, there is a risk of venous thromboembolism happening. So that is why it's considered a major risk factor. So since testosterone induces the production of erythropoietin, the most serious risk for patients taking testosterone is the development of polycythemia. This can predispose to cerebrovascular accidents. which is what I've just said. And question 4, how long after testosterone therapy should trans men consider having a hysterectomy? So they have been giving, this is a woman who wants to become a man. How long? Well, the correct answer is 4 to 5 years. Why is that important? Because when you're giving these women exogenous testosterone, although you're suppressing endogenous estrogen production, the testosterone is being converted in adipose tissue to estrogen, which then unopposed in a very, what do we call, an indirect way. So it then stimulates the endometrium of these patients. And if you continue your testosterone for a long time, then they become highly risk for developing endometrial cancer. So it is recommended that trans men consider a hysterectomy after 4 to 5 years of testosterone therapy to reduce the risk of endometrial cancer caused by unopposed estrogen produced by the aromatization of testosterone. So that is the explanation. Question 5, sorry. A patient who on cross-sex hormones wishes to have gamete storage, what recommendation will be offered to these patients in terms of what should we be doing for this patient who wants to have gamete storage? So you may have a trans man who wants to have eggs stored, or a trans woman who wants to have some sperms stored. So what should you do? So the correct answer here is C, to interrupt treatment for 3 months prior to gamete donation. So hormone treatment can interfere with the endocrine control of gametogenesis. It is ideal for the patient to be offered gamete storage before commencing hormone treatment. So that's ideal. So appropriate counseling should bring up these issues. Okay, you want to move from a man to a woman, or from a woman to a man. To move from a man to a woman, you're going to have your testes removed, or kidectomy. And if you want to move from a woman to a man, you're going to have a hysterectomy and bilateral salpingo-oophorectomy. Now, once that happens, you're going to never be able to produce gametes. So if you want to have your biological children, usually with surrogates, then we need to obtain some gametes and store them. Right? So ideally you do that before they go on a cross-hormone treatment. Now, if they haven't, then you want to interrupt the treatment for 3 months, harvest the gametes, and then recommence the treatment. What is the normal duration of gamete storage in the UK? So for all intents and purposes, this question is general. It's not about trans men or trans women. So the normal duration is 10 years, which is B. So the normal maximum duration of gamete storage is 10 years. However, in the cases of transgender individuals, this can be extended to a maximum of 55 years. Now, obviously, that's, I don't know whether the person will be strong enough to be able to have children from surrogates, but that's what the law says. So it can be extended for that length of time. Approximately what proportion of women are affected by stress urinary incontinence? It's a major problem. When you go into your exams, I can guarantee you that you have a question on, or questions on urogynecology, which covers urinary incontinence and genital prolapse. So it's something that you need to read and read it around very, very well. And you have the green top guidelines, sorry, the NICE guidelines, or you have a green top guidelines on vault prolapse. And then you have a talk article, in fact, several talk articles that refer to urogynecology. So have a read at these articles. So the correct answer here is 1 in 3. So about 1/3 of women in the UK are affected by stress incontinence. It doesn't mean that 1/3 of women will come to the clinic complaining, because some of them don't come. It's often required. It's often considered as an embarrassment for some of these women to come and say, "Look, I cannot control my waterworks." So the explanation here is pelvic floor dysfunction is a major health problem affecting many women. Stress urinary incontinence affects approximately 1 in 3 women, while pelvic organ prolapse affects approximately 1 in 9. That's the next question. So affects 1 in 9. So the next question was approximately what proportion of women are affected by pelvic organ prolapse? And I've read the explanation is 1 in 9. So move on to question 9. What is the recommended first-line management of women with stress urinary incontinence combined with mild or moderate pelvic organ prolapse? Even if they didn't have pelvic organ prolapse, the first line of management for most of these patients is physiotherapy. That's what you recommend for these patients. And physiotherapy, which in the form of pelvic floor exercises, does make a big difference. It reduces the number of women who will then require surgery, and it also reduces the number of women who may require medication in those that have an overactive bladder. So whether it's an overactive bladder or it's stress urinary incontinence, you offer pelvic floor exercises. Obviously, with those that have an overactive bladder, pelvic floor exercises will not be enough. We look at lifestyle modification in terms of their fluid intake to avoid caffeinated drinks, coffee, Coke, or the drinks that have caffeinated substances that can stimulate the bladder. The bladder has been shown to have sweet receptors, and all these drinks will stimulate the bladder and cause an overactive bladder. So you would recommend pelvic floor exercises, lifestyle modification, and then you then offer them bladder control. So you tell them to delay going for 10 minutes, 20 minutes, 30 minutes, and they keep, that's called retraining. You keep doing that until they're able to maybe hold themselves for another hour or two. Once they reach that level, most patients who will benefit from that exercise often would have achieved some improvement in their symptoms. What detection rate for a given false positive rate for Down syndrome from screening is higher is rarely matched with the method. Now, this is a question that I think has come up in exams for a few times. And so the correct answer here is D. So the detection rate of 90% for a false positive rate of 5% using an NT combined with serum biochemistry in the first trimester. And I've got an explanation here which gives you many different rates. I'm going to read that out slowly. So the detection rate for trisomy 21 has increased from 30% for a false rate of 5% using maternal age alone. So for maternal age alone is 30%. Then 60 to 75% for a false positive rate of 5% using second trimester biochemistry, which is just a combination of AFP and HCG. So you combine AFP, HCG, you get a detection rate of 60 to 75% for a false positive rate of 5%. And then when you now move on to a combination of NT, ductal venosus, absence of the nasal bone, and the tricuspid regurgitation with serum biomarkers in the first trimester, your detection rate goes up to 99% for a false positive rate of 0.1%. So, your detection rate goes up to 99% for a false rate of 3%. So that is for an NT serum biochemistry in the first trimester. So NT and serum biochemistry, the detection rate goes up. That biochemistry is PAP-A and inhibin and beta HCG. Now, if you now combine you add on top of that your nasal bone and tricuspid regurgitation, you reduce your false positive rate. And we now know that if you are offering the patient a cell-free DNA, which is a screening test, NIPT, I was going to do a 5 minutes video on this, but I haven't gotten around to do it. I might still do it before the exams anyway and place it on this website for you to have a look with some questions. Then the detection rate goes up to more than 99%. with a false positive rate of less than 0.1%. So for trisomy 21, it's 99 point something like 9 or 99.89% for a false positive rate of less than 0.1%. So that is much better. And I've had people asking the question, is NIPT now available on a routine basis in the UK? And the answer is no. It is used as a triaging for those patients who have a high screening test with an NT and or biochemistry that the risk is 1 in 150 or more. Instead of offering them a CVS or instead of offering them an amniocentesis, we offer them NIPT, and then only if NIPT is positive, they'll go on to have an invasive procedure. Okay, so question 11. A 33-year-old has been screened for aneuploidy and the result comes back with a raised risk for trisomy 21. Which biochemical marker is increased in pregnancies complicated by trisomy 21? So it's HCG. So in most conditions where you have a relatively immature placenta, as you get in trisomy 21, and as you get in patients who have a partial molar pregnancy, even in molar pregnancy, you get very high HCG levels. Now, placental associated plasma protein, PAP-A, falls rather than rises in patients with trisomy 21. So that is the correct answer. And I've got a few more questions on this. What is the detection rate when maternal age is combined with NT and serum biochemistry screening for trisomy 21 for a false positive rate of 5% at 11 to 13 weeks gestation? And the answer is D, 90%. And this table is really, really important. Now, I believe that there have been questions on this, something like this, and I'm not quite sure, but if they haven't, then you need to watch out for it, because I like it very much. So it's actually asking me the question, what are the changes in the various biochemical analytes in patients who have trisomy 13, which is Patau syndrome, trisomy 18, which is Edwards syndrome, and trisomy 21, which is Down syndrome. So a woman is seen at 13 weeks of gestation for counseling about the risk of aneuploidy. And I've got there the reference where this comes from is Evolution in Screening for Down Syndrome. It's a paper published by Kypros Nicolaides 2 years ago, I think 2018. So you see that option A, an increase in maternal age, increase in NT, increase in free beta HCG, and increase in PAP-A. And this inevitably will be trisomy 21. Then you have option B, C, D, and E. Now in trisomy 13, the placenta is small. The placenta is small, then you would expect HCG to fall because your HCG is higher in immature and large placentas, which is why in patients who have diabetes, for example, who have large babies and large placentas, you tend to get higher HCG levels. So a woman is seen at 13 weeks for counseling about the risk of aneuploidy. What changes in age, HCG, and PAP-A are in keeping with a high risk of trisomy 21? I think we all would have guessed that one. That is A. Now, the woman is seen at 12 weeks plus 6 weeks, and following counseling up to an NT measurement and biochemistry screening the first trimester. What changes in screening will be in keeping with trisomy 13? So again, I did say that that is one where you have a drop in HCG. So your other indices will be increased, and HCG will fall because of the size of the placenta. So the explanations from the article are all three aneuploidies are associated with increased maternal age, increased fetal nuclear translucency, and decreased maternal serum PAP-A. In Down syndrome, serum beta HCG is increased, whereas in Edward and Patau syndrome, beta HCG is decreased. In addition, Patau syndrome is associated with fetal tachycardia. So you can actually have another column with heart rate and then they were asking you which of these will be indicative or suggestive of Patau syndrome or Edwards syndrome. What is the impact of maternal obesity on cell-free fetal DNA? So as I was saying to you, I wanted to do a small video on this. So you need a minimum fraction of fetal DNA in maternal circulation for your NIPT and NIPD to be reliable. And that minimum fraction is 4%. Now, there are factors that will affect that percentage. One of them is maternal obesity. The woman is obese, then her blood volume is much greater, and there is possibly an impact of adipose tissue on the placenta itself, and therefore you're going to have a lower level of fetal DNA. And the results in obese, especially the morbidly obese women for NIPT, are not as reliable as you get in women who have who are lean body mass or just overweight. Now, the other things that could affect your NIPT results, of course, are patients who have twins. If the patient has got twins with one twin that is vanished, which is vanishing twin syndrome, you may find out that the twin has vanished before you do your NIPT, which is usually after 9 weeks. Most people would say from 10 weeks. The fragment of the fetal DNA from the vanished twin will still be in maternal circulation because maybe the trophoblast is still active, and therefore that may influence the fraction of the fetal DNA that you have in maternal circulation. And of course, if you have dizygotic twins, then that it's a bit more difficult. Whereas if you have monozygotic twins, you know that the DNA you have in maternal circulation is from one source, and that shouldn't be a problem. So those are the things that could influence your NIPT. Question 16. I thought I'll be going a bit faster, but it's okay as long as I'm going slow and you're taking notes and understand. That's fine. A 32-year-old primary gravida presents with acute abdominal pain at 30 weeks of gestation. What will you consider a red flag symptom? A one that requires a senior clinician evaluation. This is you will hear about red flag symptoms in patients presenting with vaginal bleeding, abnormal menstrual bleeding. They talk about red flag symptoms. If you look at the guidelines, talk about red flag symptoms in patients who have the painful bladder syndrome, because those are things that may be pointing to bladder cancer or very severe bladder pathology. Those that have the red flag symptoms in patients who have abnormal menstrual bleeding are symptoms that are pointing to possible endometrial cancer. And there were red flag symptoms in patients who present with futures suggestive of ovarian cancer. These are common things that examiners like, because in terms of morbidity, if we miss them, then we're likely to run into problems. So we've got these 5 questions here, and the correct answer is D, the pain with no established cause requiring a repeated doses of opiates. That is one that you should always bear at the back of your mind. And there's some cases where we talk about the pain that is excruciating and your opiates cannot control that pain. Then that is a red flag symptom, and that patient needs to be evaluated by a senior clinician. So just to read out my explanation here, approximately 3 maternal deaths per year in the UK are attributed to intra-abdominal pathology. It is therefore important on presentation that a thorough review is undertaken. Where there are red flags, a senior clinician is mandated, a senior clinical evaluation is mandated. These red flags include readmission or multiple admissions, repeated doses of opiates given for analgesia without a cause for the pain being established, new onset anxiety and confusion being attributed to psychiatric cause rather than underlying or undiagnosed organic disease. And it was published in Talk, Surgical Causes of Abdominal Pain in Pregnancy, and I think it was either last year or 2019. Now to probably easier question for all of you. At what urinary protein creatinine levels will proteinuria be considered significant in a 30-year-old woman presenting with proteinuria and mild abdominal pain? I think all of you should know that one. The answer is more than 30. When an automated reagent strip reading device is used to estimate proteinuria, a result of 1+ or more should lead to consideration of hypertensive disorders of pregnancy, and a protein quantification test should be performed. That is what the guidelines, the NICE guidelines say. Now, significant proteinuria is diagnosed if the urinary protein creatinine ratio is more than 30, or if a validated 24-hour urine collection shows greater than 300 milligrams per 24-hour protein. So it's either more than 30 milligrams per millimole or more than 300 milligrams per 24 hours. Question 18. Pregnancy is said to increase the risk of acute myocardial infarction in women of the reproductive age group. What is the estimated effect of pregnancy on the risk of AMI? Myocardial infarction is a very popular question for the single best answer questions, and that's because it causes mortality across all of pregnancy: first trimester, second trimester, third trimester, and postpartum. So you need to know how to make a diagnosis using troponin levels, the atypical presentations. You need to know about the ECG changes that are characteristic of or diagnostic of acute myocardial infarction. And what we're saying here is that what is the impact of pregnancy on the risk of myocardial infarction, and increases that risk 3 to 4 times. So though acute myocardial infarction in women of childbearing is rare, and the incidence is 6.2 per 100,000, that is a possible question, pregnancy increases the risk by 3 to 4 times. And then it goes on to say the risk is further increased by advanced maternal age, particularly those over the age of 40 years. AMI presents as acute abdominal pain or even symptoms suggestive of gastroesophageal reflux disease. Therefore, an ECG should be considered if you suspect. So the patient may actually present with acute abdominal pain and they have AMI. So if you can't rule out a possible cause of acute abdominal pain, especially in the women who are older, you should consider doing troponin levels as well as an ECG. Okay, question 19. What is the most common cause of acute surgical abdominal pain in pregnancy? I think all of you must know that answer is appendicitis. It is the most common acute surgical cause of abdominal pain in pregnancy, affecting between 1 in 800 to 1,500 pregnancies. Ovarian torsion is the next one, but it's not very common. And there are questions with acute pancreatitis, and the patient with acute pancreatitis tend to present with pain that tends to be either in the epigastrium and a little bit more to the back, and they tend to have a slight tinge of jaundice. So we have a patient with a slight tinge of jaundice and central abdominal pain that is radiating to the back. You should suspect pancreatitis. Cholecystitis, of course, is very typical. In most of these patients, the diagnostic feature is a positive Murphy sign. So you, as you start palpating the right hypochondrion, the liver is not enlarged, but you ask the patient to breathe. Take a deep breath in. When she breathes out, when it touches your hand, the patient jumps because of tenderness. So what is the recommendation by NICE with regards to screening for smoking in pregnancy in the UK? Again, this is a very, very important question. And you can see here that it's talking about screening. NICE recommends that we screen every woman. So all women should have a biochemical screening via exhaled carbon monoxide. So this is a test strip that you will use. So the correct answer is B. So NICE recommends that all pregnant women be asked about their smoking status at their maternal booking visit and at regular intervals during their pregnancy and puerperium. It also recommends biochemical screening of all pregnant women via exhaled carbon monoxide. This identifies non-disclosing smokers who can be referred for an opt-out basis for smoking cessation support. Referring all women with a positive exhaled carbon monoxide reading result in large results in larger numbers accessing help and support, although it does not necessarily result in higher numbers of biochemically verified quitters. So if a woman has been tested positive, then you refer. Now, one of the things that I always believed in is that the women will never, well, let me not make a generalized statement. Most women will not honestly tell you how many cigarettes they smoke a day. The woman says, oh, I smoke 1 to 2. Actually, she's smoking about 10 to 15. I smoke 5 to 10. She's smoking 20 to 30 cigarettes per day. Or I don't smoke. I smoke very occasionally. Well, she's actually smoking on a regular basis, but she wouldn't admit it, which is why NICE is saying that actually let's offer it to everybody. Then we will then find those that are not admitting. The same principles apply when any woman in the reproductive age group goes to emergency in the UK with abdominal pain, they will have a pregnancy test. Now, that is a rule that applies to everybody. Now, when this was being discussed, there were arguments about, okay, what of women who come in and say, look, my daughter is not sexually active, why are you doing it? Well, it's a general rule applying to everybody. So if your daughter is not sexually active, it shouldn't be a problem. With regards to smoking cessation during pregnancy, what proportion of quitters in pregnancy remain abstinent 1 year postpartum? Now, you can see that I got carried away and I had 6 options instead of 5, but it doesn't matter. Those of you who are smart enough would have ignored option F, but it's always not like that. As you've probably seen one of the questions that I have, that option F is indeed the correct answer. But in this one, the correct answer is option E. So unfortunately, there is a high rate of relapse, with many women smoking again before the end of pregnancy and the early postnatal period. Less than a third of spontaneous quitters in pregnancy remain abstinent 1 year postpartum. Women who are single and parous, so these are the at risk. The woman is single, she's parous, or women who have partners or household members who smoke, and those with high depression scores and a heavier smoking habits pre-pregnancy are most likely to relapse in the postpartum period. Breastfeeding mothers are less likely to relapse, which is why you want to encourage women to breastfeed. What is the single best predictor for postpartum relapse in a 30-year-old with multiple sclerosis? So, which women are going to develop problems post-delivery? As it did the age at onset, the pre-pregnancy relapse rate, the relapse rate during pregnancy, response to multidisciplinary team therapy, or type of multiple sclerosis. Well, the answer is the pre-pregnancy relapse rate, which is B. So women with multiple sclerosis appear to have fewer relapses during pregnancy, but relapse during the first 3 to 4 months postpartum is not uncommon. So 20 to 30% of female patients. The single best predictor for postpartum relapse is the pre-pregnancy relapse rate. MS relapses occur less often in parous women, and pregnancy after MS onset is associated with lower risk of progression. The recent systematic review confirmed that pregnancy does not alter the risk of MS or long-term progression. So that's another question. How does it? Oh, I think that's the next question. A 35-year-old primary gravidae who suffers from multiple sclerosis is in labor at 40 weeks of gestation. She has been offered an epidural for pain relief. What is the possible effects, if any, of the epidural on her disease? So the answer is it has no effect. I was going to say that another question that can come is what is the effect of pregnancy on MS, and it has no effect. So here, the explanation is that I've given here is most new relapses involve different symptoms that have not presented before, whereas most new relapses manifest as a flare-up of all symptoms. So I've gone OTT here, sometimes with greater intensity. For example, the development of painful visual loss or optic neuritis in a woman who had never experienced visual symptoms before suggests a new relapse, whereas relapse, oh, what is this? Anyway, I'm going to skip to women must be reassured that there is no increased risk of relapse with the use of vaginal anesthesia, especially epidural. So it has no effect on relapse rate in these patients. Question 24, what is the estimated proportion of patients undergoing major abdominal surgery who will develop adhesions This question has come up in exams before. You have a midline operation. What is the risk of adhesions? That risk is up to 90%. That is how high it is. It's up to 90%. So the development of peritoneal adhesions following surgery is a complication that can have a significant impact on patients and the wider healthcare system. It is estimated that adhesions may develop in up to 90% of patients undergoing major abdominal surgery and 55 to 100% of women undergoing pelvic surgery. So up to 90% of patients undergoing major abdominal surgery. And then for those that are undergoing pelvic surgery, so limited to the pelvis, the risk is 55 to 100%. What is the gold standard measure to take to prevent the formation of surgical-related adhesions? And this is a very important question, even for your own clinical practice. Now, although I'm a fetal medicine person, I am also minimal access surgery. I did a lot of laparoscopic surgery, or do a lot of laparoscopic surgery, and I consistently use ecodexin, which is quite expensive. But randomized trials show that icodexin actually was only 51% compared to 49% if you used normal saline or if you use Hartmann's. And so it isn't that effective, and it's also very, very expensive. And now I just use Hartmann solution, but the most important or the gold standard is meticulous surgery. If you handle the tissues much less, you reduce exposure of the tissues to dehydration, and then you also reduce the blood that is left behind that will stimulate inflammation and adhesions, then the risk of adhesion formation is much less. Those that do surgery very quickly and say, look, I can do a hysterectomy in 20 minutes or 30 minutes, then lift minor bleeders and say, look, this nature will sort itself out. It's great for your ego to say, look, I do this in the cesarean section in 20 minutes, 30 minutes. But actually for the patient long term, you've left bleeders that cause multiple adhesions. And so you'll find those who do meticulous surgery, they will take moist salines and just damp the bowel if the surgery is going to be extensive, and that reduces the risk of adhesion formation. Okay, question 26. A 56-year-old is in the clinic complaining of urinary incontinence. She's evaluated and referred for urodynamics as there is a suspicion that she may have mixed urinary incontinence. So mixed is a combination of stress and an overactive bladder. She attends for urodynamic testing, and an initial urinalysis reveals plus nitrites and plus leukocytes. What would be the next step to take in her care? This is also a popular question at the exams. Now, this patient doesn't have, well, urinary incontinence itself may be a symptom of urinary tract infection, but she doesn't have the obvious symptoms of urinary tract infection. There are some that will come with symptoms and some that will come with no symptoms. And NICE clearly has a pathway, the NICE guidelines has a pathway on how these patients are managed. And so for these patients who has urinalysis revealing plus nitrites and plus leukocytes, we know that if you go and you put a catheter in the patient's bladder, you actually increase the risk of the patient having ascending pyelonephritis, which has got a severe morbidity. So you want to treat the patient with antibiotics, postpone urodynamic until you've cleared the infection. So the correct answer is A. So it's prior to commencing urodynamic testing, urine diptych must be performed. So that is a single best answer question you can have to check for infection or hematuria. There is evidence of urinary tract infection, then the test should be postponed until infection is treated. There is a risk of UTI when performing urodynamic testing anyway overall. A review of 9 randomized controlled trials showed that prophylactic antibiotics reduces the risk of bacteriuria and hematuria following urodynamic testing, but not of symptomatic UTI. Therefore, the potential benefit of routine prophylactic antibiotics do not outweigh the potential clinical and financial implications. So what we're saying here is that if we're saying urodynamics increases the risk of UTI, Should we therefore be offering prophylactic antibiotics prior to urodynamics to every woman? And what I have said here is that no is the answer, because although it might benefit a small number of women, the evidence is not strong enough to say let's offer it to everybody, like prophylactic antibiotics at the time of cesarean section or major abdominal surgery. I'm sure most of you have seen our article on surgical site infection, which was published in talking about the use of antibiotics to reduce the risk of surgical site infections. Okay, 27. A 1-hour pad test is being performed on a woman as there is discordancy between urodynamics and her symptoms. What would be considered a positive pad test? There are two types of pad tests. There's a 1 hour, there's a 24-hour test. And the changes in weight are different with both. The 1 hour pad test is not as reliable. So the 24-hour pad test is more reliable and it's much more reflective of what is happening. So you need to know what the differences are. For the weight gain for 1 hour, we take 1 gram. For the weight gain for 24 hours, we take 1.3 grams. The 24-hour, the patient will wear the pad, then change it every 4 to 6 hours, and either weigh the pad or freeze it so that it does not, the air does not go and act on the urine in the pad, in the pad and change the weight of the pad. So the answer here is 1 gram, which is A. And I'm going to read this because it tells you about the reliability. Pad tests can be performed to detect and quantify severity of urine loss if urodynamic observations are not accepted by the patients who have not produced results explaining their symptoms. They will not, however, give a diagnostic course for the urinary incontinence. A short-term test over 1 hour involves wearing a pre-weighed pad and instructions to exercise for 30 minutes. Before and after weights of the pad determine the amount of leakage and are more accurate if based on a fixed bladder volume. A positive test is weight gain of more than 1 gram. The long-term test, usually performed over 24 to 48 hours at home, allows women to go about their normal activities wearing the pre-weighed pad and correlates well with symptoms. The pad is changed every 4 to 6 hours and is either weighed immediately or stored in an airtight bag for later weighing. The weight gain of more than 1.3 grams is positive. So the difference, so this question can be changed into a 24-hour pad, and then you have 1 gram, you have 1.3. The answer is 1.3. I'm going a bit slow. I think I need to go to work. For how long will, question 28, for how long will early absorbable sutures like polyglycolic acid support the vaginal vault after surgery? The correct answer is 3 weeks. So the type of suture material used affects the incidence of vaginal curve dehiscence. The use of early absorbable suture is associated with a higher incidence of vaginal curve dehiscence than when delayed absorbable sutures are used. And so the rate is 2.5 if you use the ones that are absorbed very quickly versus 0.7. And I've actually seen a patient who came to the emergency in Leicester with bowels coming down the vagina 3 weeks after she'd had a vaginal hysterectomy. She's had a vaginal a vault dehiscence, and then the bowel came down. So it's really important. So this can be justified by the fact that early absorbable sutures like those made from polyglycolic acid can effectively support the wound for 3 weeks, while delayed absorbable sutures such as those made from polydioxone, which is PDS, are supportive for 6 weeks. So some people would prefer to use PDS because it lasts a bit longer, but Vicryl, which lasts for 3 weeks, is good enough. And the last question, what is the primary therapeutic effect of acupuncture is mediated by? The correct answer is B. It's a combination of sensory nervous system stimulation, an increase in the release of neuropeptides, an increase in blood flow. So that is a discussion on the single best answer questions. I thought I was going to go very quickly and take questions, but I'm sorry I'm going slow. I need to leave here for 12:30 to go to work, so I've got 40 minutes to go through the 15 EMQ questions. So see what happens when I go through the 15 EMQ questions, whether we'll have time at the end to take questions. If I haven't answered questions, you have really burning questions, I will go to talk to Mutada, who is the expert that runs this website, to allow me to answer some of the questions that you pose in writing. So if I can answer the questions, I'll do that in writing. So the EMQ questions. So the first one is, all these women are pregnant and present with acute abdominal pain. Choose from the option list the single most likely cause of the abdominal pain. Each option may be chosen once or more than once. That's always the skill that we give for these questions. Oh, someone could not join the meeting because it's full. I'm sorry, I really don't know what to do. I'm going to get away from this. A 26-year-old prima gravida, BMI 30, who is 20 weeks pregnant, presents with severe abdominal pain at 12 hours duration. The pain is, I say, with nausea and vomiting. She says the pain is mainly on the right side. She's examined and found to be mildly pyrexial and tender in the right region. A full blood count shows a mild leukocytosis. This thing keeps showing. The webinar has reached its full limit of 101. I don't know what to do. I don't know whether Mutada is available, but he may be able to sort that out. It's examined and found to be mildly pyrexial and tender in the right region. Oh goodness, this thing keeps showing up, so I need to hide it. A full blood count shows mild leukocytosis, and ultrasound scan, not can, does not show any annexal mass. Think about it. Mild pyrexia, systemic symptoms of nausea and vomiting, and then a mild leukocytosis. It points to the most likely answer is appendicitis, which is A. A 40-year-old gravida 3 para 2, BMI of 37, who is 26 weeks pregnant, presents with abdominal pain. I'm sorry, I was going through this very fast. I didn't actually read through. Of 3 days duration and a fever. So all of you must have spotted that this was, I was talking about pain here. The pain, which is mainly in the right upper abdomen and radiates to the back occasionally, is made worse on eating. She is pyrexial on examination, but not jaundice. There is tenderness in the right hypochondrium, especially on deep palpation with inspiration. So that gives it away. And I did say to you that if somebody's got cholecystitis, Murphy's sign is positive. And so the correct answer here will be cholecystitis. Obviously, a differential diagnosis is pancreatitis, but in pancreatitis, you don't have a positive Murphy's sign. Question 3. A 30-year-old gravida 1 para 1 was admitted with progressive abdominal distension and constipation 2 weeks after an emergency C-section for fetal distress in labor. That statement alone would point to 3 things: either a bowel obstruction, one form of bowel obstruction. It could be small, large, or pseudocolonic obstruction immediately. So I was saying the answer is either H, J, or Q, the way it's presented, because it's after surgery. There was no associated pain, so that immediately rules out most cases of mechanical obstruction, because with mechanical obstruction, you get colicky pains. So at that point, I can stop and say, I know the answer. The answer will be Ogilvie syndrome. Your pseudo-obstruction, this question has come in the exams. It also comes from an article that Dr. Pradeep and myself published in Talk a few years ago. So it goes on to say, when examined, she was apyrexial, but the abdomen was distended with normal bowel sounds. You can have mechanical obstruction with normal bowel sounds. She was treated with lactulose with no relief. She remained in discomfort, and the day after admission, she developed shoulder tip pain, which later became colicky, central abdominal pain. She had pars platus, was yet to open her bowels, and there was no vomiting. Plain radiographs revealed widespread colonic dilatation with no free fluid. So the answer is Ogilvie syndrome. Just excuse me, please. I'm going to send a message to Dr. Mutada about this pop-up message that keeps coming. Okay, sorry about that. Just this thing keeps popping up and blocking my screen. Okay, question 4. A 30-year-old gravid at 2-para-1 previous emergency cesarean section for fetal distress who is 24 weeks pregnant presents with abdominal pain associated with nausea and vomiting of 3 days duration. So unlike the previous one, where the patient presented with progressive abdominal distension, this one comes with pain and vomiting. So we know that, again, is either going to be large bowel or small bowel obstruction. It could be Ogilvie's, but it's less likely. The pain is colicky and has been getting worse. She's vomited 4 to 5 times today, and the vomit is now greenish. Now that gives it away. Greenish vomit is highly suggestive of a small bowel obstruction. All right, so the answer is Q. Question 5. A 33-year-old gravid at 2-para-0 who is 28 weeks pregnant presents with fever, acute abdominal, low abdominal pain, and nausea and vomiting. The pain is predominantly on the flanks. So what it's telling you is if the pain is mainly on the flanks, at that point, I was saying this is more likely to be a kidney problem. It doesn't say one flank, flanks, both of them. So she says that she has also been having intermittent pains mainly in her back, which started shortly after the pains in her flanks. Her urine is concentrated and indeed described as dark colored. That gives me an answer. Pains on both flanks, backache, highly concentrated urine, which is suggestive of blood that has been hemolyzed, and she's got a temperature of 38.2, the answer is only one option, and that is pyelonephritis. So I hope you're following the logic behind how I arrive at the answers, because that's important. I don't care whether you got the answer right or not, but what is important to me is understanding how we arrive at the answers, the things that allow me to say this is the correct answer for you. Question 6 to 7. These women present with symptoms of vaginal estrogen deficiency. Choose from the option list the single most appropriate first treatment option. Each option will be chosen, blah, blah, blah. A 65-year-old postmenopausal woman is not sexually active. Who is not sexually active presents with vaginal dryness and irritation of 6 months duration. She does not have any other menopausal symptoms. There is nothing relevant in her medical history. So these patients, you choose a single most appropriate first treatment option. This one is not sexually active. She presents with vaginal dryness and irritation of 6 months duration. The recommendation is to give her something that is local. The first treatment option doesn't say what is the most effective. The instructions are the first treatment option. That's something that most of you would have omitted. So the correct answer here is E, moisturizers. So vaginal lubricants and moisturizers are used to reduce vaginal dryness and pain during sexual intercourse in women with mild to moderate vaginal dryness. The effect of vaginal moisturizers is longer lasting than lubricants. Moisturizers are therefore not only used by women with vulvovaginal symptoms who have painful intercourse, but also by symptomatic women who are not sexually active. It is the treatment of first choice recommended by the British Menopausal Society in managing women who present with vaginal atrophy as in these patients. Now, if you are going to then look at, if this doesn't work, what will be the next option? You'll be looking at vaginal estrogen cream as the next option. A 60-year-old who is known to have mild osteoporosis presents with vaginal dryness, painful sexual intercourse, and irritation. She's otherwise well. So here we have a different scenario. The patient has got a pathology that is linked with estrogen deficiency. So we give her moisturizers, which I've told you last longer than lubricants. They will not be effective. They will control vaginal dryness. They will perhaps be useful for the painful sexual intercourse and irritation, but they will not be useful for osteoporosis. So the correct answer here is a systemic estrogen, or HRT, and that answer is K. And the British Menopausal Society recommends that when symptoms are predominantly vaginal or urogenital, topical treatment should be used. However, in the presence of vasomotor symptoms or osteoporosis, systemic HRT is best used. So systemic is usually oral. That is the best one, rather than vaginal. Now, you can say transdermal. Would transdermal be considered systemic? The answer is yes. Transdermal is also systemic because it gets absorbed into the system. So systemic hormone replacement therapy here will cover oral, transdermal, all right, as your HRT. Now you may say, what's intravaginal dehydroepiandrosterone? Well, it isn't really an estrogen in this patient because DHEA, and that is not as effective in these patients who have osteoporosis. Question 8 I think question 8 to 12. This question is taken from the confidential inquiries into maternal mortality. And what I'm trying to say here is that please, for those of you who will be coming onto the course, there's a very nice lecture by Dr. Victor Chilaka on maternal mortality, and he essentially summarizes what you need to know from the latest report. So an hour for you to go through the slides, and I'm not sure whether I have any questions attached to that lecture. I can't remember. Each of these women were reported in the confidential inquiries, and I can guarantee you that this is the biggest audit in the UK, and for most exams, there's usually a question or two from this from the report. Were reported in the confidential inquiries into maternal death in the UK and Ireland in 2019, covering the triennium 2015 to 2017. Obviously, a report was covered published last year, covering 2016 to 2018. But I think most of these scenarios will be applicable. So for each patient, select from the option list the single most likely cause of maternal death. So a 30-year-old, and these actually are narratives of women who were reported in the report. So this is not my imagination. These are women who died in the report. So a 30-year-old gravida 1/0 presents to emergency department with severe back pains at 30 weeks of gestation. At her booking visit, she had given a history of aortic dissection in the family. On examination, she had a systolic hypertension. While being assessed, she complained of severe abdominal pain and collapse and died. So I think all of you would have figured that out. This is aortic dissection. And in fact, my advice to you is, apart from, for those of you who join the course next week or the week or in June, and it doesn't really matter whether you join or not. My objective is to help you to pass exams. If you go to read the report, you don't have to spend too much time reading every single page of the report. Read the summary of the report and then look at the typical clinical scenarios, because that is where the examiners would take their items for EMQs. they would take the items, have a list like this one, and then flag up those individual patients. And then if you've read them, it'll be very easy for you. So the correct answer here, of course, is aortic dissection. Question 9. A morbidly obese woman who had recently given up smoking was admitted twice in the 3rd trimester with chest pain and breathlessness, which progressed to become prominent on exertion by the 2nd admission day. I will stop there and say, what are the risk factors? This patient's got risk factors. So what are those risk factors pointing to? Number 1, she's morbidly obese. Number 2, she is smoking. Number 3, she's in the 3rd trimester with chest pain. 3 risk factors pointing to AMI, acute myocardial infarction. That, at that point, you pause and say, well, that's got to be the answer. Then you go on. Chest pain, morbidly obese, smoker. What we didn't tell you here is the age of the woman, because I told that she was 37, because this particular patient who died was age 37. Then you put all of that together and say, well, I know the answer. So she gave a history of heart disease at booking. Again, another pointer. On both occasions, she was investigated for presumed pulmonary embolism and discharged after a negative result. She collapsed 3 days after cesarean section and died. So she died from acute myocardial infarction. You might say, what are these chest pain that she was talking about? Well, you have very tiny AMIs that were not picked up, and then she developed a massive AMI and died. An obese gravida 3-para-2. So again, another patient, obese, smoked, consulted her GP in the 2nd trimester with severe central anterior chest pain relating to the jaw. That gives it away, and the left arm, and associated with sweating, nausea, and dry retching. So I don't need to read the rest of the answer to know that this is, again, a case of acute myocardial infarction. Think about the risk factors that we talked about earlier. Obese, smoking. Then we've got central anterior chest pain radiating to the jaw and the left arm. Sweating, nausea, vomiting. It goes on to say the pain came at rest and lasted an hour. Cardiovascular examination was normal, and ECG on 2 occasions showed no ischemic change. She was admitted and given aspirin and investigated for pulmonary embolism. D-dimers were raised and troponin levels were also ordered, but results were not yet available. The pains persisted. On the 3rd day, she was found dead in bed after an episode of further pain. So what the CMA's report flagged up in this case was that here we have a woman, major risk factors, classical symptoms, and the doctors were busy pursuing pulmonary embolism as the cause of the chest pain. She died at a post-mortem examination, and acute myocardial infarction was the diagnosis. A woman with complex social situation and previous mental health problems attended 3 times in late pregnancy with different concerns, and on each occasion was noted to have tachycardia. That is the only thing that is in that sentence, tachycardia. Unexplained tachycardia. So if you read the report, it will tell you that unexplained tachycardia is flagging up a patient at risk of a cardiomyopathy. That's what unexplained tachycardia. So if the patient's thyroid function is normal, she's not anemic, there's really no reason why. We know that in pregnancy, the heart rate goes up, but you will not classify that as unexplained tachycardia. So when you see that, then think about cardiomyopathy. So here we have a woman with a complex social situation, and the mental health problem. These are distractors, and this is what happened in this particular scenario. Because this patient had a complex social situation, the clinicians were ignoring the telltale signs. They were saying that her tachycardia was due to anxiety. She was reported to be very anxious and discharged home. That's what they said. Oh, she's very anxious, she's got all these problems, let's discharge her home. In labor attempts, she remained tachycardic and continued to be postpartum. She was thought to have sepsis and started on antibiotics and appropriate investigations undertaken. But she had been investigated antenatally and no evidence of sepsis. So she took her own discharge and 3 weeks later presented with acute breathlessness and tachycardia, and she died shortly after presentation, and a post-mortem showed that she had cardiomyopathy. So the clinicians were initially thought she had sepsis, she had PE, and that's why, but the tachycardia is said to be unexplained, but they kept backing the wrong tree. Question 12, a young woman with a complex social history, including substance misuse, had a normal birth. Now we have a clue, a substance misuse, most likely somebody who injects. She presents with feeling sweaty, with aches and chest pains 2 weeks later, and was advised to see a GP after review and discharge. Again, substance misuse, feeling unwell, sweaty and aches. We're looking at, if somebody's got repeated substance abuse and presents like this, you must think of infective endocarditis. She collapsed and died at home, and the post-mortem confirmed that she had died from infective endocarditis. Okay, the last set of questions, questions 13 to 15. This, I think, is a past MRCOG question. I think so. My memory is not that good as far as this is concerned. So choose from the option list above the single most likely cause of amenorrhea in each of the patients. An 18-year-old presents with primary amenorrhea and mild lower abdominal pain. 18 years old, primary amenorrhea. Remember that we will diagnose problems in a patient who doesn't have any secondary characteristics at the age of 14, right? So this one is got, they don't tell us anything, just it had primary amenorrhea with mild abdominal pain. So it's most likely that she would have had, she has all her normal secondary external characteristics. Otherwise, I cannot imagine a girl who is 18 and never had a period and doesn't present to the hospital. So that is an assumption you have to make when you read this. She's mainly in, the pain is mainly in the left iliac fossa, which started 3 years ago. You examine and find a mass in the left iliac fossa, which is Virgo intact. So what is that telling me? It's telling me that she has a problem with the Mullerian system. That is most likely an incomplete system where she has a rudimentary horn. That rudimentary horn, she's been bleeding inside and bleeding inside and bleeding inside, and it's getting bigger and bigger. And I manage a few of these. One of them, I was actually a young girl who I saw at the age of 16. She had been through the surgeons, orthopedic surgeons, gastroenterologists, psychiatrists, and then one of our medical students, interestingly, was one who said, look, Professor Konje spoke to us about these kind of things, and they talked about girls that can present this way, and they said, okay, let's ask them to come and see. And I went to see her, and we did a scan, and we found a rudimentary horn with a liter of blood. And so the correct answer here is Mullerian agenesis. Now you can have complete Mullerian agenesis and incomplete, and this one would have been incomplete Mullerian agenesis, and that is O. So question 14, an 18-year-old with primary amenorrhea and poorly developed breast, she's examined and found to be short stature with a murmur in the heart. That short stature, murmur in the heart, poorly developed breast is what? Turner syndrome. So you look at the option list, I don't have Turner syndrome. Is this guy who's called Konje is crazy. Why doesn't he have Turner syndrome? Because I want you to think, why do patients with Turner syndrome have a problem? All right. So, oh, what have I done here? So I'm reading, what have I done? So blood sample sent for hormone profile shows raised FSH and low estrogen levels. So no, the ovaries are not there. She's referred to a cardiologist and a diagnosis of quadrigen of the aorta is made. Oh, okay. So I think it's part of my explanation. I didn't delete that properly. So I had 45XO and I took it out. So this woman has got the genesis of the gonads because of 45XO. And the point I'm trying to make here is that if you had 45XO there, that will be the correct answer. But because 45XO is not there, you have gonadal dysgenesis. If you had 46XY gonadal dysgenesis or 46XX gonadal dysgenesis, those patients you don't typically are not short stature and they don't have the cardiac problems that you have. That's the point I'm trying to make in this question, and that's a question that came up in the exams, I'm sure 2 years ago or so. And the last question, a 17-year-old presents with primary amenorrhea. She has 2 sisters, both of whom had their first period at the age of 12 and 13 years respectively. Her breast developed at the same time as that of her sisters. She mentions on passing that she has been experiencing myoabdominal pains that are increasing in severity for the past year. So she's found on examination to have a normal height, well-developed breast Turner stage 4, normal pubic hair, and normal external genitalia. So you have this patient who presents with normal external genitalia. She's got well-developed pubic hair, all right, and you've got amenorrhea. So the question is, what are the options here? Now, the 2 options here are mullerianogenesis and androgen insensitivity syndrome. So the 2 options. So how do you distinguish between the 2? Okay. Now, the only thing that will distinguish between the 2 in this patient is the pubic hair distribution. So in the patients who have androgen insensitivity syndrome, the pubic hair tends to be sparse, and it tends to, in some patients, be typical of the male pattern rather than the female pattern. So here we have well-developed breast, normal external genitalia. She has experiencing lower abdominal pain intermittently, which again is pointing to rudimentary remnants of the Mullerian system. So this patient has got mullerianogenesis. Now, with your classical androgen insensitivity syndrome, the examiner will tell you that the vagina is blind, short acting, and they often say that the young girl is sexually active. Okay, so I've got one. Oh, I thought I'd finished. So this is one more question. Interesting. So a 16-year-old is in the clinic because of primary amenorrhea. She has well-developed breast and sparse pubic hair. There are bilateral inguinal hernias and normally developed labia. No masses were palpable per abdomen, and ultrasound scan fails to show any pelvic structure. So here we have something different. Bilateral inguinal hernias and sparse pubic hair. So this one would be complete androgen insensitivity compared to the other one. So I hope you see the difference. And you have palpable, no, she has bilateral inguinal hernias. Again, you will see them classical in those that have androgen insensitivity syndrome, where you may have the testes may actually be in the labia, or they may be retracting from the labia into the abdomen.